So let's talk about some of the answers to those big questions that folks are asking when they first start to meet with you. For example, is it safe to be on hormones? Am I too old for hormone replacement therapy? And what are the risks for being on hormones? Which one do you want to tackle first?
Let's do, is it safe?
Mm-hmm.
That's the most common one. People are, women and physicians, actually the population, have been told for decades that estrogen causes breast cancer. And that soundbite has rippled through the medical community for years. And there are physicians who still believe that to today, even though the one study that promoted that soundbite, the Women's Health Initiative, has actually gone back and say, well, really, estrogen doesn't cause breast cancer. It reduces the risk of breast cancer if you have the Premarin alone. It reduces risk by 23% if you take it for 5 years or 6 years. So it's actually a risk reduction. But doctors don't know that. So I spend a lot of time educating women that really, if estrogen was a problem, if it wasn't safe, then all women and you would have breast cancer.
Mm-hmm.
Okay, so if that's the case, every woman should have breast cancer. It's not. And estrogen is the hormone that makes women women and propagates the species. So, it's important. I would say unopposed estrogen is a problem, right? If you give unopposed estrogen, meaning estrogen all the time without progesterone, then we know, at least in the setting of the uterus, it's accepted that if you don't give progesterone with estrogen, you can cause uterine cancer with unopposed estrogen. And so my thing about safety is that, yes, estrogen, you can take estrogen, but you should take it with cyclical progesterone, even if you don't have a uterus, because the hormones are a body-wide signaling event, not just a local event. And so your breast tissue is also susceptible to that same hormonal pattern. The estrogen rise first, the progesterone rise second. Normally you'd have a period, but that whole pattern sets you up for health. So I would say estrogen is good. And it should be given with progesterone, and preferably in a cyclical manner.
Mm-hmm.
And there's studies, I can go into the studies about that too, showing that cycling is definitely better on the body than continuous combined. But
what about, am I too old for HRT? If I'm in my 60s or even older than that.
So that's a newer thing that's happened recently, and that's because of the Women's Health Initiative again.
Right, scared people. Yeah.
Well, it's because they took women who were 50 to 60, or 50 to 59, 60 to 69, and 70 to 79, 3 groups, 30 years. And they put them on hormone replacement with oral Premarin, which is and it's conjugated equine estrogen. It's the horse urine metabolite, right, plus the progestin. And we know the progestin, not progesterone. It's really important. I think people are figuring this out now, finally, after 20 some years. Progesterone is not the same thing as a progestin. So the progestins are the ones that are showing risk for more complications with the hormone therapy. I don't even prescribe progestin, so it's just not even on my plate to talk about. Anyway, when they did the study, the women who were 50 to 59 had an all-cause mortality reduction, even with the drugs with hormone effects, okay? So some hormone is better than no hormone in that period of time, okay? So women live longer, they live longer, they did better. And again, timing matters, right? If 50 to 59 is right at menopause. But if you were given these same drugs with hormone effects at age 60 and 70, you didn't have the same benefit and you had a little more complications. So at this point in time, we do not recommend, as a blanket statement, not to give women who are over 60 hormone replacement. Now, that is specifically for the study using Prempro, which is the synthetics, the, Premarin and the progestin Provera. So those are the synthetics, not real bioidentical hormones like estradiol and progesterone. So that's why that is, being, doctors are afraid to prescribe at this point in time, because that's a guideline from a lot of the endocrine societies and the Menopause Society and ACOG, which is gynecology. So these are the guidelines, and people are afraid to go against them.
Okay, thank you. And then lastly, you kind of already addressed this, the breast cancer risks and the risks of being on hormones.
Well, there are lots of reasons and lots of risks for breast cancer. And I think that's, a lot of people don't understand that, actually. When I meet a new patient for breast cancer who has a breast cancer diagnosis, I can find multiple risks, not one risk, but multiple. And even you're just having dense breast tissue, which a lot of women have, can increase your risk for breast cancer. And it's not so much, not all dense breast tissue is a risk, but there's probably a subset, and we just don't know who they are yet. But there's something about the environment of the breast that it might promote breast cancer. That's one. Genetics, obviously. There's, the typical BRCA gene, PALB2, and CHEK2 genes now that are higher risk for breast cancer. But even things like, there's things like, having your first child after the age of 40, that's the highest reproductive risk factor for breast cancer. And it's one of those things right now where women are thinking, oh yeah, I can go to school, I can get my, go to school, I can work, I can get married later, have a kid after 40. Yeah, well, that's all possible, but there's biological risks for that. And that's not really talked about. You can reduce your risk of breast cancer by having your first born baby, under the age of 30, and then breastfeeding that baby reduces risk. But over the age of 40, increases it 4 times. Then,
interesting.
Yeah.
Yeah. So what I hear is that there are a lot of risks for breast cancer that have nothing to do with taking hormones.
Correct.
Yeah.
Correct.
Great. Thank you. You heard it here first. So let's talk about some of these symptoms and how we address these symptoms. So folks are coming in with weight gain, lack of libido, energy, they're not sleeping well, and or a mood disorder. And it could be all happening at the same time. And they are probably feeling, again, if they're in that 20% where it's really highly agitating, is this normal? Am I crazy?
Yeah.
How do we address these symptoms? How do you address these symptoms?
Well, just so you know, for most of my practice, I was in oncology for a gazillion years. So I would see people who already had breast cancer. And actually what I appreciated was how we treat estrogen receptor positive breast cancer is we basically castrate all those women who have that diagnosis. It's a blanket, here's a pill. We will give you tamoxifen or an aromatase inhibitor if you're postmenopausal. But what we're really doing is shutting down your estrogen. And so I could see what happened to women in that setting, but I also knew how important, estrogen was. So I saw the breast cancer population first. Okay. And so they are the ones that I could see literally fall off a cliff under my nose and medications. And so, and some women had a few symptoms and some women had a lot of symptoms. So just so you know that the reason why I got into the hormone replacement for breast cancer patients was because these women didn't want to live like that. I don't want to live feeling nothing. I don't want to live like whatever. They just didn't want that. And of course, we have drugs for those things, right? We have drugs for sleep. We have drugs for, joint aches. We have drugs for osteoporosis. We have all of those things to address, but the people just don't want that. So that's when I started giving their hormones back with their understanding this was their decision, and I would support it for their
Well,
quality of life.
and the reason that these symptoms are showing up is because, you know, when you're going through this menopause transition, depending on where you are, your phenotype, your genetic history, your estrogen and your progesterone levels are declining. And then these symptoms are showing up.
Correct. So then we go back to your question, how do they present? So that's, for me, it was all over the map for that population.
Yeah.
But in my current practice, again, it's mostly the sleep. It's mostly the weight gain. You're right, because we become insulin resistant when the estrogen is gone.
Yeah.
Not everybody, but certainly the majority of people.
Mm-hmm. So if folks are coming in with these symptoms, or even to kind of get ahead of the bus that we know is coming, but many of us didn't know was coming, like myself, at 35, I wasn't thinking about menopause. I was actually living in the Bay Area, and I remember hearing a lot about Sarah Gottfried, who is an incredible champion and pioneer in the space, just like you are, Julie, and has written lots of books and done a lot of research on supporting women through menopause. But I just thought, oh, that's way later. I don't need to address any of that, not realizing that I was actually maybe not experiencing symptoms at 35, but I definitely was experiencing them in my late 30s, if I'm really honest with myself. And I could have had my hormones checked then, had I been knowledgeable enough to ask my GP and my women's health doctor to look at them. And I would have been able to advocate for hormone replacement therapy.
Maybe, maybe, because maybe now, but even a handful of years ago, I don't think so.
Yeah.
Because doctors they wouldn't want to test your hormones if you're having a period. And of course, that's the biggest fallacy, right? You could be having a period and your hormones are going boom, 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 despite having a cycle every month. And so doctors will go, no, you're fine, but you're not fine because you're not sleeping, you don't have a libido, you're irritable, etc.
Yeah. So
definitely symptoms you can check. But the problem also is that even though I wouldn't, if you're having a period or you're having some symptoms, your estrogen may not be low when you have your blood test. Okay. And that's one of the problems with perimenopause. You fluctuate.
Right.
And so it could be hit or miss in terms of getting an accurate test that reflects your symptoms. So it's really a combination of your symptoms, the cycle. Is your cycle changing, right? Could be changing a little bit. Is it getting lighter? Is it getting heavier? Is it getting shorter? Is it getting longer? Might be some clues that things are changing. But if you're going to think about it, yes, you want to get tested for the estradiol. I also test for estrone. I test for DHEA, which is an adrenal hormone that will convert to estrone in the postmenopause woman, because the estradiol, which converts from testosterone in the ovary and from the ovary itself, will be gone by the time you're in menopause. So you have to look at several of those hormones, right? And your FSH, to look at your brain signal to your ovary. So if your FSH is high, I think most people will say, oh, that's a no-brainer. You're in menopause or perimenopause, but sometimes it's not.
Right.
Sometimes the FSH is not as high as you think it would be because they're fluctuating. So.
And would you also test progesterone and thyroid as well?
I would. Okay. If you're going to do that, yeah, I would, because I like progesterone and I like to test it. I like to test it on day 21 of a 28-day cycle. Day 21, 22, because that's when it would be at its peak. And so I would know if you're making enough progesterone to be really cycling, right? Did you have enough estrogen or enough estradiol to pop an egg? And did that egg, was it, good enough to produce enough progesterone in the corpus luteum? So, it's helpful to know when you do your hormonal timing as well. Okay.
And what if you're working with a patient who is not cycling on their own? How would you address some of these levels?
So if they're not cycling it, then it doesn't matter. You can just get your test done on any day. So if someone's in menopause, for instance, at this point in time, I've been doing this. I don't need tests anymore to know that you don't have hormones, at least the sex hormones. Okay.
Yeah.
But, perimenopause, no, you should get tested. And even if you're having any time in between, periods, my period was 2 months ago, I would still get it. You just don't know at this point in time.
Yeah. Okay. That's really helpful. So I know we've been talking a lot about hormones and estrogen and progesterone. Let's go into that a little bit deeper. So what is a hormone?
Well, hormone is a chemical messenger that's made from, a gland. And the ones that we're specifically talking about are really produced from the hypothalamus that signals into the anterior pituitary. And those hormones that are made in the anterior pituitary, like the FSH for
follicle stimulating hormone for folks.
Follicle stimulating hormone that stimulates the follicle to make estrogen. And, there's a bunch of other neighboring cells that produce things like TSH, so thyroid stimulating hormone, adrenocorticoid stimulating hormone. So they all are produced in that area. And trust me, they all work together and like a symphony, okay? But when the FSH signals, it leaves the anterior pituitary and it goes technically to the ovary to stimulate estrogen production. So there's a body-wide connection here of the signaling, okay? So that's what a hormone is. It's really a chemical messenger starting in one place that has an effect on another part of the body.
So what are the benefits of estrogen? We've been talking a little bit about them. I would say let's talk about the benefits versus the negative implications of not having estrogen, but it's solving for some of these symptoms that we're talking about.
Well, for estrogen has over 400,000 or 4,000 that I can look at. Functions over 4,000.
And we have estrogen receptors all over our body as well.
We do, except I think a red cell, something like that. It's almost all cells have estrogen receptors. So it goes from, we can start from the top of your head, like your hair, your follicles, your skin. Your brain has estrogen receptors all over the place in your brain. Your eyes have it. People, who are in menopause have dry eyes. It can be reversed with hormone or estrogen replacement specifically. Dry mouth, same thing. Dry skin, wrinkles. Estrogen controls the skin. All right. So that's just starting from the head. What about things like your mouth and your teeth? Absolutely. Estrogen controls bone. Your teeth sit in the bone, in your jaw here, and you can have teeth problems because the bones are weak. And you see that in women now who've been on birth control pills for like 30 something years. They have more jaw and teeth problems now because birth control pills lower estrogen levels ultimately. But even things like your stomach acid is controlled by estrogen. Your peristalsis, having estrogen changes your gut microbiome. So your bones, your joints, I can go on.
And then it also it impacts metabolism and our ability to become more, insulin adaptive versus insulin resistant.
Absolutely. Thank you. Of course, I was giving all the structurals, but the metabolic issues, absolutely. We talked about insulin resistance, but the other thing that's important is that estrogen also helps ATP production. So that's your energy production.
Mitochondria.
It absolutely has an effect on the mitochondria. So in terms of mitochondrial health, hormones are important.
Let's talk a little bit more about the estrogen effects on metabolism.
Let's see.
Since weight gain is something that a lot of women are experiencing and or complaining about.
This is more complicated. It's more complicated because what I basically tell people is the situation is such that if you eat one cookie, your body thinks you're eating 10 and it acts like it's eating 10. And
I think that's a very simple explanation. That's not complicated at all. That's great.
But that's what it is. And it's just that estrogen will And it has to be it's not just some estrogen, it has to be the right amount of estrogen, can reverse insulin resistance.
Mhm.
So again, might as well make the point that in terms of estrogen replacement, estrogen is dose dependent.
Mhm.
So some estrogen may be helpful to reduce or help you sleep, but it's going to take a lot more estrogen to maybe get your brain to function online
Yeah.
and
Yeah.
maybe metabolically.
Mhm.
So medicine has not completely caught up to that yet.
Mhm. Mhm.
They have different doses in terms of the patch and the pills for estradiol. But there's only this range of dosing because that's all that's been studied. And so doctors don't give any more what's been studied, even though somebody might need their dose out here.
Yeah.
They don't address that.
And so it sounds like in your practice that you're addressing a person's estrogen needs where you might actually give them more than maybe what the patch is administering.
I do. Yes, I
Yeah.
do. Because I don't need a blood test to tell me that, they need more estrogen when they're not sleeping well, or they still wake up with hot flushes
Or their brain's not, rebooting in the way that it used to. Yeah.
correct. And as long as we look at other things too, right? We have to look at thyroid and other hormones that go with this because they all work together.
Right.
But yeah, and how they're sleeping. Are you sure you didn't have a
Mhm.
insomnia from
Mhm.
snoring or
Mhm.
apnea or whatever? So you have to make sure you're not missing any of those things.
Yeah. And we're talking a lot about the benefit of hormones, but I also know that you're a big believer in other lifestyle changes as well. And so, like, for example, if we're talking about symptoms related to sleep and also weight gain, obviously getting as much as you can a good sleep hygiene practice. And also, if you know that your body is actually going to be holding on to more of those sugars and isn't able to burn the glucose as much, then probably eating more protein. And in fact, that's recommended for women, period, that we need to be basically eating 20 to 30 grams of protein with every meal. Most women are not doing that. And usually having more of a ketogenic diet, which means that our carbohydrate intake is mostly coming from fruits and vegetables, not from processed foods, not from foods like breads that are going to actually have more sugar content. And that's just my food as medicine, nutrition background, and also what I've been really experimenting with in myself in the last year.
I agree with you, except that my peanut M&Ms do provide me with some protein.
Yeah, and then there's like organic almond butter and raw cacao powder. So, but yes, and obviously you're doing the right things because look at your physique. But let's talk a little bit about brain health and the important function of estrogen in brain health, and actually how important that is. That finally, hallelujah, there's been some research to be done on what is actually happening in the menopause brain. Could you speak to that a little bit?
Well, what's really interesting is that there's always been research on estradiol and brain function in women. It just hasn't gotten the press that it's needed all this time because we've been living in the estrogen causes cancer era. So nobody wants to know that. So did I know that estrogen was really good for the brain for the last 25 plus years? Yes. Because even things like with the Alzheimer dementia, there's a relationship with estradiol and reducing the beta tau tangles, the beta tau proteins. So you need estradiol to make a certain enzyme that cleaves the proteins to keep those levels down. So that kind of information on Alzheimer's was always out there. But the thing that's new now is that they're looking at the hippocampus and hippocampal volume, which is where your memories are stored.
Right.
So we know that women who are on hormone replacement maintain their volume, and women who are postmenopausal without hormones have a smaller hippocampus that might relate to maybe memory changes. So it's a physical change, a structural change, has some huge clinical implications.
And then Dr. Lisa Mosconi, who's been doing research on the menopause, female brain, she has also found that around age 43, this is where progesterone really starts to decline, but also estrogen is fluctuating wildly. And some of her research is pointing to that if women are, well, first there's something called cerebral hypermetabolism, which is really showcasing that women in this stage of life are having a lot of cognitive impairment, memory deficits, as you just said, because of the hippocampus being affected, and just overall cognitive decline. And there is research showing that women really need to be getting on hormones 5 years preceding menopause to reduce the influence of Alzheimer's and more cognitive impairment. What do you think about that?
Yeah, that's really, you bring up really good, a couple of points. My head's going all this way because I have so many things to tie together. One is, I just want to point out that the brain has a lot of progesterone receptors. It's a ton of progesterone receptors in the brain. So again, not having progesterone when you're given estrogen as a replacement, you're missing brain health, okay? Or supplementing the brain health with that. Also, we know that there's some other theory that's it's still considered to be viable today, is that you shouldn't start hormone replacement until a year after menopause. Okay. Yes. That's been, going around for quite a while based on, I could say, the elite studies and other thing. But really what's happening is if you start the hormone replacement first before you hit the menopause and you have nothing, you'll maintain it's really the lining of the vasculature, the lining of your brain, the lining of your heart. So you're not going to drop, you'll hopefully maintain and continue your brain health and heart health without a drop. So, and honestly, I agree that I have to say that I started doing my hormones when I was 40, and I wasn't really, I had a different story, but I I had an injury and I was inflamed from a musculoskeletal side. And so I didn't have hormones, although I was having periods. My hormone levels were like in the single digits at that point in time. And so I started taking hormones, and then I realized when I started doing that and I upped the hormone dose, it was my best month, and I turned around and recovered. I was out of work for a year because of this. And then when I took the hormones and upped the dose, I said, oh my gosh, my brain is clear, my body doesn't hurt. And even though I was having a period, it was just kind of a memory thing, not so much of a big functional thing because my levels were low. And then, so I've been on it since the age of 40, and I'm 65 now. But my bones for an older Asian woman are like bricks from the hormones. They're super strong.
Amazing.
So on the metabolic side, I said, and my heart's fine, and I hope my brain's fine. I'm sure it's okay.
I've had a couple conversations with you. I think it's pretty stellar. Well, that's amazing that you were able to get on early, and hence why you've been such a pioneer in advocating for hormones. I mean, as you said, you already knew about the science 25 years ago, but this study with PET scans that Lisa didn't even come out until 2018. And that finally got some public attention. And, I hope there's going to be more and more research as well.
There is more coming.
Yeah. But we've talked a lot about estrogen. In the time that we have left, let's go into the beauty of progesterone, and just some of the benefits that progesterone can deliver to our lives when it's declining at age 40 and ongoing.
So, progesterone's really important. I think it's kind of the sister to the estrogen, but it's probably the most important hormone because it is considered to be a master hormone. Okay. So your body makes progesterone always from your adrenal gland. Okay. So you get cholesterol, metabolized, and then the next step after, that's the second step, it converts into progesterone. And so progesterone is the parent compound for many of the steroid hormones. So testosterone, estradiol, aldosterone, cortisol. Okay. So it's even, depending on where it's made is where what hormones are produced. So super important hormone. Okay. So you have to have it all the time. So when you're reproductive, it is the ovary egg that makes progesterone, and it makes it into higher levels, higher doses, and that fluctuation of high and low tells the body different things. Okay, these rises and falls of hormones aren't there for willy-nilly. They're there for reasons, and they tell the body things are happening or going to happen, and get prepared. And they make receptors, they make all kinds of physiological changes, and really, yes, in response to potentially getting pregnant, but it does keep women healthy, right? So progesterone, it is like the chill hormone. It's the calming hormone. It is the peacemaker in that regard. It helps you sleep. It helps the smooth muscles. It reduces smooth muscle contraction. So again, this is the relaxation. If you're talking about a gut, yeah, it could cause constipation. So you have to be careful. But it can also help with skin. It can also help with, brain function. It can also, even help with hot flashes for someone if they get progesterone alone. So, and in the uterus, we see the biggest change. We've known that forever, is that when you have the uterus, the lining thickens with the estrogen, right? And then progesterone is made, and it converts that lining into a secretory lining to be prepared for pregnancy or to have a period. So there's a conversion there. And really, that conversion also results in things like increasing P53, which is our anti-cancer gene, right? It's our tumor suppressor gene, keeps us from getting cancers going wonky. So it's huge. It's gigantic. The estradiol at peak levels too does the same thing. High levels of estrogen
reduces P53. Interesting.
It increases P53.
Oh, it increases P53,
yes.
which is reducing our cancer risk. Yes. Got it. So it's interesting that you said so many things, but when I go back to one of the symptoms that most women are, complaining about or being alerted to is all the mood fluctuation, right? Like inability to regulate, hypersensitivity. And that's happening because the progesterone is declining. So we are not able to calm the brain in the way that we used to. And do you want to say something else? Yeah.
No, you're correct, but it's estrogen too.
Right.
It's both hormones.
And one of the things that I recently kind of just got, what do I want to say, re-alerted to is that, when we're going through a stressful situation, we're producing more cortisol. But if we end up having a lot of cortisol will borrow progesterone to actually create more cortisol. So then the more stressed we are, we're losing our progesterone, which is actually allowing us to calm down and be more regulated. And then we're having more stress hormone. And I did a lot of neurobiology research where we were looking at the long-term benefits of meditation as it related to telomere length and cortisol. And so cortisol hormone is also related to abdominal fat. The more that we have, the more. So again, it's just like this cycle that influences everything.
So true. It's called the cortisol steal pathway. Yeah. Thanks for bringing it up, but you're absolutely right. Progesterone, as I said, it was the master hormone. And if there's a lot of stress, you're right, it's going to funnel progesterone away from everything else just to make cortisol. So the body's so fascinating and complicated.
And you and I have had some side conversations around thyroid and how that's impacted, by this change in hormones. Could you speak to that a little bit? Why is the thyroid being more we could say stressed, challenged, as estrogen and progesterone are fluctuating and declining.
Yeah. So my understanding is this. So women start to lose, I would say, let's start at the age of 40, because they're losing their hormone levels, et cetera.
Yeah.
Women tend to become more autoimmune between 40 and 50 at the menopause site. Women just get more autoimmune in that time. But what's happening is really a loss of progesterone, and progesterone really is our biggest anti-inflammatory hormone that we have, right?
Mm-hmm.
Because obviously it's there when you're pregnant so that you don't reject the embryo that's present. So that's one of its functions, one of many gazillion functions. But it is our most anti-inflammatory hormone. So we have estradiol, we have progesterone. And so when you lose the progesterone, maybe you don't have the anti-inflammatory, period of time, and women might get more autoimmune going into menopause.
Mm-hmm.
Thyroid is our number one
Mm-hmm.
one autoimmune issue.
Mm-hmm. Yeah, 1 in 5 women have Hashimoto's, which is the thyroid autoimmune disorder. And what was I going to say about this? I was going to share that brain fog.
No, it has to do with, we're talking about progesterone and hormones, and why are you becoming more autoimmune during that time?
Yes.
So I was just saying that we may become more autoimmune because we're losing our progesterone.
Right.
Okay.
Right.
So that was my one piece.
And what's interesting about the thyroid is that if your thyroid is off, your hormones, even if you're taking hormones, your hormones won't be regulated.
That is absolutely true. You can have, if you have hypothyroid, people know it's going to affect your period if you're young, right?
Yeah.
You can't get pregnant, your period's not right. And the other thing I've noticed, like in the breast cancer setting, right, if you have a postmenopausal woman, and we put her on an aromatase inhibitor, which basically cuts off all estrogen production, the TSH will rise. Okay, so there's a thyroid signal that's going out to the thyroid to make more thyroid hormone because the estrogen's not happening. So it's all continued, not continued, they're all related. So you can become more hypothyroid when you don't have your estrogen on board.
And this is what I think has given me so much compassion for women, 40 to 50 and above, especially kind of in the sandwich generation where folks that are in their 40s are probably have children of their own. They're starting to take care of their elder parents. They're maybe at the height of their career and in more senior level positions. So therefore, there's more stress related to that. And so when you think about the amount of stress that we're navigating and then this reduction of hormones that are happening at the same time, of course, it would impact the thyroid and the adrenals. And if we're not testing for thyroid and we're not testing for these hormones, then we don't know how to advocate and find healing. So that's why I'm having this conversation with you, is to bring more education and awareness.
But testing is important because if you go to your doctor and you say, I want to test my thyroid, what are they going to test?
TSH, which is not enough, which is what I have learned. If anyone wants to talk about thyroid, I know everything about thyroid right now.
So it's really like almost a mandate in mainstream medicine that if your TSH is normal, not to get a T3, not to get it. So nobody wants to get it anymore because we've been told not to get it. Even though thyroid is in a feedback loop, right? So you have your TSH, your T4, T3, and it all funnels back to the brain. It doesn't make sense to look for one part of it if you're not, in general, if you're healthy, it should work.
Right.
But it doesn't happen all the time. You can have symptoms and a normal TSH and they go, oh, you're fine.
Right. And then you're not looking at the antibodies as well, the TPO, the TGIO, and most people are not also looking at your reverse T3. If your T4 is converting to T3, then it's fine. But it's either going to revert to T3 or reverse T3. And if you have antibodies, then you likely have too high reverse T3.
And not enough T3, free T3.
Right.
functionally
Right.
free.
Right.
Yeah.
So thank you so much for weighing in all of this. I have two more questions, and this is really about, what you're excited about, what you think is possible for the topic of menopause as far as medical education for just regular practitioners, OBGYNs that actually still don't have enough professional education around menopause, and the research. What do you think is possible? What do you think is needed?
Well, in terms of excitement, I'm just excited. Like now, here we are, 2025, we're just starting 2025, and menopause and hormone replacement therapy is a hot topic. Okay, so finally, it's taken a minute, but it's happened, and so that's exciting to me because I feel like I've been in the basement trying to
promote
myself.
it. Yeah.
With a few of us, I should not by myself, but a few of us who know how important it is. So that said, I'm really excited the fact that it's just now being talked about. What I see that's really needed is some uniform premises, because now what's happened, I think people are, talking all over their theories. Like, this is what I think, and including myself. I mean, I have my own theory about how hormone replacement should be done, or preferred. It's not a one size fits all thing, but preferred. And people are making statements, and it's like, well, we don't have the research to back that up. So, so I would like to hear more, better studies, and we have to spend a lot of money to do that. That's the biggest problem. But more money onto studies that look at different types of hormone replacement therapies. And because just FYI, I just there was a paper that recently came out and saying that progesterone given vaginally is probably our best mode of delivery for a woman. So I have to look at that a little bit more.
Well, right, because oral progesterone, sometimes people don't always have the best response to that because it has to go through, the stomach versus a cream, or what? Right? Why not just put it where it needs to go? Correct. With the vaginal progesterone? That makes sense.
So, we call that when you take it through your mouth and you have to digest it through your stomach, we call that a first pass effect.
Okay.
And so it goes into the liver and goes into a bunch of metabolites. And so that's not how the normal body does it. Normally it just secretes progesterone into the bloodstream and then gets to the liver. So it's a different process. Anyway.
Well, Julie, we could talk about this all day. Thank you so much for weighing in on this really important topic. And for those of you that want more time with Julie and would love to ask her more questions, if you join the Radiant Transformations program, you will have that opportunity. And you can, of course, always reach out to her at her website. And she's also on LinkedIn.
Yeah. Thank you.
Thank you, Julie.